Hi, everyone. Um, Kaya Jurczynska on this end. Forgive me, I'm actually not going to show myself on camera because I'm a bit under the weather, and it's best I stay off. You'll just have to trust me on that one. But thank you very much for joining me for this session. I'm a senior technical advisor with the Health Policy Plus project. And this session specifically is on how insights into inequity can be used to drive family planning decision making. Just give me one moment. Okay, fabulous. So, over this last year and a half, 2 years, we developed a new tool under HP Plus, and that is called the Family Planning Equity Tool. It's really a method for identifying inequities in family planning for a diverse set of commonly disadvantaged subgroups for various components of family planning, not just use. So we look at other facets of family planning programming. And you can also identify inequities not only at the national level, which of course is valuable, but you're also able to diagnose inequities at the subnational level as well, which is super important for programming and financial decisions. So by doing that, the tool identifies who is experiencing inequity, what component of family planning is being delivered inequitably, and where that inequity is concentrated across a country. The purpose of these results is to help individuals make decisions about family planning programming. So, where we focus our resources, which subgroups we focus on overall. It's certainly important policy decisions if we're seeing that certain groups of individuals are being consistently treated inequitably or facing inequitable outcomes. What the tool is actually code for R, the programming software, that you apply using the data from the Demographic and Health Survey. We've also done this now for PMA, and so it's also possible to use it for different survey types, but really DHS is still the winner here as far as what the tool is best utilized for. So you can see on the right-hand side the approach for diagnosing inequity in family planning, and there you can actually find a really handy replication guide. So even if you're not super familiar with R, the content therein should help you do this application on your own. And in order to do that, there are a few key steps. So basic setup. After you do that in R, the code automatically runs a series of statistical computations for you, and it tests specifically the experience of 7 commonly marginalized groups of women across 5 components of family planning programming. And if one of these groups has a statistically significantly worse odds of receiving that component, it is considered an inequity. And you can see a basic screenshot from the software here. This is actually our code fully loaded. Don't let it intimidate you. Again, the user's guide is really a good series of steps to do this, even if you're relatively new to R. All right. So as mentioned, we are testing the experience of disadvantaged groups across different family planning program components. It's not just about whether you're experiencing an equitable outcome in family planning uptake. We really want to go beyond that, given that family planning services are so much more. So as far as the groups that we test, we take a look at women by education, by age, by wealth, by marriage, ethnicity, residence, and religion. And we compare the experience of the minority to the majority in the cases of religion and ethnicity, the least educated to more in the cases of education, the youngest to older, wealth, the poorest to richest, and so on and so forth. And we do that comparison for the measures that you see below. So we take a look at something like access to family planning information, access to services, acceptability, quality, and use. And we can, during the discussion portion, talk a little bit more about the actual indicators that are used to measure each of these family planning components. You can see them listed here, and I'm happy to answer more questions at that stage. So in terms of the results, you can use the results as evidence for your FP 2030 commitments, as well as those within cost implementation plans. Of course, in those, we have high-level goals, but oftentimes we like to also say a few more words about how things should be targeted, which groups should receive a service, and so this analysis can really help you develop those types of commitments. Importantly, if you're able to see where family planning inequities are concentrated, this can be used to help you prioritize where you spend your money inside a specific country, as well as on what. And that just will improve your allocative efficiency overall. And finally, I mean, it relates to the funding point, but once you are able to see where the inequities are found and for whom, it's certainly evidence that can be used to better tailor and direct your family planning program activities. For instance, again, you can figure out where they need to go, which components need to be bolstered, and so on and so forth. So let's take a look at the application results for two countries, and you can get a sense of what the results can be used for and what they typically show. So Uganda and Bangladesh are two very different cases as far as just their modern contraceptive use. You can see that Uganda exceeds 38% and is growing, whereas Bangladesh is at a considerably higher level, exceeds 55% MCPR, and is at this point but a bit stagnant and constant, and that's expected as we make progress along the S curve. But the inequity profile is very different. So the next row, you can see that inequities across family planning components or regions are actually pervasive in Uganda, but they're actually very rare in the case of Bangladesh, and you'll see that on a map in just a moment. In terms of the components of family planning that are delivered most inequitably, for Uganda, it's access to services. So your interactions with healthcare workers and the extent to which they tell you about family planning. And in Bangladesh, that's access to information, and that's proxied by or measured by your exposure to family planning mass media. And lastly, the most commonly disadvantaged subgroups in Uganda, those are the young and unmarried. And in Bangladesh, those are the least educated and the poorest. So that's already giving you a little bit of an indication about what programmatic components you should be focusing on and for whom. So let's take a look at Uganda, a deep dive, access to services. On the left-hand side, you can just see the basic DHS statistics for the percent of women who were told of family planning by a provider at a facility. What this is telling us is that access to services is really relatively low in most regions in Uganda, where less than 40%. So that's just the absolute level. But what about the inequity profile? And for that, you can see on the right hand of the screen here. So for each of the regions of Uganda, where you see the orange is where there's an inequity. So if you just pay attention to how the visual distribution of the orange, it's telling us two things. Firstly, that the youngest and unmarried women are experiencing the most inequitable conditions when it comes to access to services. What you can also see by just the row view is which regions are experiencing the largest share of inequity. And so in this case, we see that a few regions, four groups of women are experiencing inequities. So Teso, for instance, Toro, three of the subgroups experience inequities. And that can also tell you how to prioritize your investments across regions. And a quick look at Bangladesh. Now, this is access to information. You can see the absolute levels, the mean values from the DHS on the left-hand side. And the story is that the exposure to family planning mass media is pretty poor in Bangladesh overall. And then to the right, we can see the inequity profile, and it's showing us similarly to Uganda that there's a concentration of inequity among two groups. And here, those are the least educated and the poorest. So that's helping us again think through who needs better services when it comes to access to information. So in terms of using these results, what do we know from what we just presented? Well, first is that poor access to healthcare workers and low exposure to family planning is certainly being aggravated by inequities in both countries. But how do we address this? In the case of Uganda, one option may be to build the capacity of the capacity of facility and community level healthcare workers on family planning, sensitization, and counseling, ensuring that healthcare workers have the skills and competencies to engage with those who are young and unmarried, because again, in that case, we saw that those were the two most disadvantaged groups. Bangladesh showed us a different story, and it was about access to exposure to mass media. And so the takeaway may be to develop and implement more family planning mass media campaigns overall, and to curate messages and access channels for those who are most disadvantaged. And those are the least educated and the poorest groups. And that represents about 13% of Bangladesh's population, so it's not insignificant. Last but not least, When we think about how we then need to target, for Uganda, we should be targeting family planning outreach to areas where the most disadvantaged groups reside. It's the young and married again. And in Bangladesh, ensure that family planning mass media is accessible in areas where where the least educated and poorest are concentrated. So thanks very much for your attention there. Um, for any resources related to this tool, you can see the link at the bottom of your screen there. And I'll pause to see if there are any questions or comments. Thank you very much. Sorry that you're hearing my sniffling as I'm pausing to hear. I'm curious if anyone on this call has experience applying this model or has seen any of these results so far, whether you have any ideas about how we could improve the utility of this tool. Anything else? All right. Well, in that case, I think we've also been instructed that we can let people go back to the main room if there's nothing further. I'm happy just to stay on if anyone would like to have a chat about this in a few moments if any questions come to you.